It's my pleasure to be here today. I'm probably not going to be as eloquent as our previous speaker because I'm just not, and I have to flip the pages to come to my presentation, but it is my pleasure to be here today and talk to you about state's commitment to movement from that volume care to a value care. And as you know, we have been traveling through the state, and you will see my co-panelist later on, Ryan Ash. We have been traveling through the state of New York for past 3+ years talking about this movement that OHIP is on of basically rewarding that value care that all of you provide. So today I will be talking to you about contracting and the contracting concepts for value-based payment. But before we go there, I wanted to tell you a little bit, this is just a little agenda of what I will be talking about. So we'll talk about overview arrangement types and contracting entities. That's the very first thing, is just a basic quick introductory of the subjects. Then we'll talk about key concepts of the value-based contracts and MCO provider contracting lifecycle, which is what many of you want to hear about. A little bit about patient-centered medical homes and changes that state has proposed just in a recent Medicaid update, and then value-based payment progress and update to date. It's basically what we have collected in data to tell you how we are progressing. So we'll move on. Let's see if this works. It does not. I think you'll be my clicker. Thank you. Okay. Another click, please, Dr. Foreman. Thank you very much. By the way, Dr. Foreman is my primary care physician. And I did not bring him with me. He just showed up alone, which is awesome. So the very first chart I'm going to tell you about, and many of you that have been in a value-based payment arena, read our roadmap, and been to MRT website that talks about value-based payment, have seen this chart in some shape and form. This is basically just to summarize what type of arrangements we, as Department of Health and OHIP, have recognized to be our go-to arrangements. The ones that we have spent probably a year plus, if not more, actually the last 3 years, defining, fine-tuning, and then posting information about on the MRT website. So those are those population-based arrangements and the bundles or episode care-based arrangements. And you know, our most common, the one that we definitely have providers engaging in, is a total care for general population, or TCGP, just for the acronym. That's what I will be using for. I am from Department of Health. We do use acronyms. Total care for special needs population, and those special needs populations are listed here. You have HIV/AIDS, MLTC, and a HARP population. And then bundled or episode care arrangements, such as maternity, and then integrated primary care, which I think you guys are all familiar with. So this is just for introduction. I think you've seen it before, and I'm not going to spend too much time on it. So next slide, please. This, again, another introductory slide just to talk about levels of value-based payment and what do we in state consider to be a value-based payment. So the yellow highlighted areas are VBP level 1s, level 2, and level 3. Those are the state-designated value-based payment arrangements, right? Level 1, you are probably familiar with. It's upside-only risk-sharing type of arrangement, where the payment structure is pretty much stays fee-for-service, but there is a potential to actually generate some savings if that arrangement's a value-based, and then we'll talk later a bit about what are components of a value-based arrangement. Level 2 type of arrangement, it's the upside and downside risk sharing. Again, payment structure and payment methodology is probably still fee-for-service, maybe some prepaid capitation, but largely fee-for-service. And then we go to the level 3 value-based payment arrangement. Jason Helgerson tends to call it the nirvana of the health insurance because everybody's prayed in this PMPM type of environment, or per member per month environment, and then everybody just do what they need to, and they don't have to worry about volume or what type of service they provide. So that's basically it. Just a quick summary of what arrangements we have. We also recognize the level 0 value-based payment arrangement. We do not call it a value-based payment arrangement, but we do understand that folks have started innovating and moving towards the value before we as a state started talking about value-based payments. So there are contracts that are in existence that have almost all attributes of a value-based payment arrangement that folks are providing care and services under, but maybe are missing certain components, maybe a quality metric, maybe a target budget, maybe that very important subcontract with a community-based care organization. And those are the only aspects that make them not be into one of those 3 other arrangements. So We actually in the state are working on some strategies how to reach to providers and the payers that have majority of their contracts in this value-based payment level 0 arena, and help them actually provide some help and some resources to help them move towards the level 1, level 2, or level 3, wherever providers feel comfortable. So next slide, please. Thank you. So another sort of introductory slide, just who are the players currently. The very top, it's the payer or that Medicaid MCO, Managed Care Organization. And as you see, MCO holds a certificate of authority given to them by Department of Health pursuant to the Public Health Law, Article 44. The Independent Practice Association, or an IPA, as you see, it's an organization that contracts directly with the healthcare providers and also provides the network to the MCOs. The Accountable Care Organization, it's an organization of clinically integrated healthcare providers that provide, manage, and coordinate healthcare, including primary care, for defined population. And as you all know, there is a Medicare ACO. The fact that CMS designates somebody to be a Medicare ACO does not designate him to be a Medicaid ACO. There is a separate application to become a Medicaid ACO. IPAs, those independent practice associations up above, may be certified by DOH as an ACO, but an ACO is not an IPA. And then for Medicaid only, and for commercial health insurance, an ACO must be approved as an IPA in order to contract with the providers. Providers, I don't think I need to talk about this. You guys know what are providers. And then that set of IPA, ACOs, and providers are actually contracting with MCO for provision of healthcare services. MCO also contracts with the management contractors who provide those management type of services. They basically delegate some of their management and oversight services down to these providers. An example of those are pharmacy benefit manager or dental benefit manager, or maybe even behavioral health manager to some degree. Next slide, please. Thank you. This is actually a very basic chart that explains the contracts. And this is what we've been seeing even now when we're moving towards the value-based payment. So MCO contracts with the IPA or an ACO, and that IPA and ACO subcontracts with a downstream provider for provision of services. That's one type of arrangement, or the other arrangement is a direct contract with a provider. So if you click a couple times, there'll be some other things that show. I'm very bad at doing PowerPoint slides, so this is my animation. The best I can do. So what we have seen as we were moving towards the value-based payment, we've seen that these basic contracts that have been in existence for 20 plus years since we had managed care in New York are pretty much still there. What is happening in a value-based payment as we're moving towards that value-based payment in these level 1, 2, and 3s, what these contractors are also doing, MCOs and IPAs are establishing addendums or appendices to their contracts just for the purpose of the shared savings arrangements. That's what we've been seeing, that's what we've been approving, and that's what we've been deeming either level 1, 2, or 3. So there is an underlying base arrangement for provision of services going by these boxes in whatever arrangement type. And then there is an additional contract signed between the MCO and an IPA or an ACO for shared savings. So if you can move on. I got to click several times, sorry. This is just the flow of funds. I think you might have seen this slide and the one that follows. It's just an example of how the funds flow in arrangements such as total care for general population. Basically, the Department of Health sends dollars down to the MCO. MCO contracts with the IPA for provision of services, passes that dollars either as a fee for service or PMPM. And then there's all these different players that are providers that actually contract downstream with the IPA. If you hit another slide, this is just an IPA to IPA contract as well. It's really just for the provision of funds. There's extensive set of slides in the value-based payment boot camp, year 1, I think, that actually goes a little bit in a further detail of how the dollars flow. So you may want to look at that resource and check it out in more detail. Actually goes through each and every arrangement. There is one for integrated primary care. There is one for maternity. I just picked this one just as an illustrative purpose. Next, please. Thank you. So the next we'll talk about these key components of the value-based payment contracts and MCO provider contracting lifecycle. There's lots of clicking in this one, I'm sorry. So first, just to set the stage, to tell you what are the components of the value-based payment contract. And the very first one is a measurement period, right? in order to know what we do, we need to have that time period. Usually that's annual. Some of the contracts might be 2, 3, 5 years. But for value-based payment, what we have been seeing, what has been submitted to us, it's probably annual contracts. We have some pilot arrangements with certain hospitals, and there's, I believe, 6 or 8 pilots that we have approved. They have a 2-year contracts because there is a very specific parameter built into the pilot contracts where in a year 1, these contracts have to have a level 1 VBP arrangement with that upside savings only, and in a year 2 of a contract, they have to move and graduate to that level 2 VBP arrangement with a shared upside and downside risks. So measurement period, for the sake of argument, we'll call it an annual. Target medical budget. This is a key, and this is one of the reasons why some of the value-based payment level 0 contracts are really not value-based payment, because they don't have that target budget. So in order to create a change, you have to set up a base level. Target budget is basically that base level. In a roadmap, we have provided an example of how entities may decide to set that target budget. Is usually based on historical costs, and then some risk specifics to population, the incentives and whatnot that you want to add in order to measure, to put that sort of a base level to which you want to hit, and on base of what we will be sharing savings and losses with the providers. Target budget is negotiable. It's something that plans and providers negotiate during the contracting negotiation phase. And as I said, we gave you some ideas in a roadmap how to set that target budget, but we did not mandate it. Arrangement types and services included. Those are those 4 arrangement types, or more than 4, that I mentioned in the very first slide: total cost for general population, total cost for general subpopulation, maternity and integrated primary care. And there is actually a specific set of services that have to be included for each and every one of those arrangements. We have clinical advisory groups that have met throughout a hefty part of our 3 years moving towards the value-based payments to sit and define what types of services fit best with arrangements that we proposed and kind of highlighted as OHIP's preferred arrangements. And those booklets, we call them the CAG playbooks, are also available on MRT website. One thing that happened as we started moving to the value-based payment in the state is that Department of Health became more transparent. So everything we do, we post on our MRT website, and our specific side of that website is the value-based payments reform site. So every meeting that we attend, it's posted there. Every presentation that we have shared with any group is posted there. All the clinical advisory playbooks, the quality metric playbooks, everything's there. So we put tons of resources out on our website in order to help actually move to that value-based payment. Attribution, another one that's negotiable, right? That's basically who are the members that you're proposing to care in this arrangement that you're setting forth. In a roadmap, which is our Bible, in a roadmap, we actually did give you some idea who are the drivers of attribution. And let's say for the maternity bundle, that's the OB or the clinician who actually takes care of the person. For the integrated primary care, that's the insurer assigned PCP, and so on. There is probably a couple pages of text that talk about attribution, who are the drivers, what is attribution, what is probably most optimal attribution in order to help facilitate the change. Another one that we did not mandate, we left that to providers and payers to negotiate on, but it's a key component of the contract. Shared savings and losses, this again, it's a negotiable. It's basically what payers and providers think works for their arrangement. Important to remember here, level 1, VBP payment, upside only, it's still considered a value-based payment and still adds to that 80 to 90% goal that we as a state need to achieve. So do not worry about moving towards level 3 prepaid capitation or level 2 upside and downside risk sharing. You can start with level 1, test the waters a little bit. Maybe you want to stay there, maybe you want to move towards a more risky arrangements. It's perfectly fine. Shared savings are key component of those arrangements, so and that's negotiable. We did provide in a roadmap, again in Appendix X and again on page 20, we provided the minimums and maximums for the for shared savings based on the quality indicators that are achieved or quality scores that providers and payers achieve. Just look at that as well. Quality measures. Our clinical advisory groups worked very, very hard to come up with a set of measures that will be pertinent to each and every arrangement. Those are pretty much the measures that MCOs and providers have been used to, and MCOs have used them in the past. Those are your HEDIS and QAR measures, most notably, and then some additional measures that are very specific to each and every population or arrangement that we picked. These measures are updated annually, and I believe that 2018 measures have been posted on the MRT website. It is important for the value-based payment to be valued and counted as a value-based payment to have at least one pay-for-performance category, one measure tied to the shared savings. And that those ups and downs in that measure will actually determine how much of the savings or losses providers will suffer. Financial protections are an important piece of the negotiating the contract, just to ensure that the provider does not suffer major losses by providing the care, and then also that those members that are attributed to that provider are taken care of and receive the services they need to. We'll talk in a couple, further along, we'll talk about a couple financial protection slides. Reporting, it's negotiable. And we tell people, and you'll see through the life cycle as we go about that, we tell people to put reporting measures in a contract, put more frequent reporting just because data is the key. You don't know how the contract is progressing, is it meeting the requirements of the contract unless you have that communication back and forth between the provider and the payer, so reporting is important. Next slide, Dr. Foreman, thank you very much.
Excuse me?
Yes. Yes, please. Sorry. Okay.
So the implication, I'm wondering where the CBO is in this picture. So is it only that value-based payment arrangements will exist with CBOs that are part of IPAs, number one? And then number two, so what about independent CBOs? And can you talk about the three levels, the tiers, and how that'll all work, A? And B, on the next slide or the slide after that, when we're talking about measures related to this, how does social determinants of health get factored into the valuation, and are CBOs at the table with those discussions?
There's a breakout session on CBOs later, in a little bit later today, and I think we do have a CBO expert here from the Department of Health who will be talking about it. It's not my strong suit, but I'll tell you a little bit. What we have been talking, these slides have been done before, like in very early stages of the value-based payment, and I put them in just as an illustration of how the money flows. But CBO is one of the providers down below, right? We consider in a state CBOs basically to be equal to providers. One thing that we have most recently found out is that CBOs, and it really ties to a contractor, that CBOs, because of the size of the organizations or even the experience in the arena of the Medicaid, some of the contracts we require with the CBOs are with the Tier 1 CBOs that do not bill Medicaid directly. They do, in state eyes, CBOs are providers, but really on outside world, they provide valuable service, but are not treated because they're not licensed by the Department of Health to be a provider. So we have heard from managed care associations that CBOs have had a hard time signing the contracts because they have never had to do that before. CBOs provide service as a subcontractor. The MCO provide either housing or maybe the food or whatever types of service that they provide, but that's on a subcontract. So what we are doing actually, it's amending some of our contracting requirements for the CBOs, because we originally looked at CBOs as be this very narrow look at them and like their provider and treat them pretty much same as the physicians. But we realized that that's not what CBOs are because we don't license them. So we are working on, and Martina will tell you about that later in the afternoon. We're working on a template arrangement or agreement or a contract, for better lack of terms, that CBOs will have to actually go and approach MCO with, that will help you navigate the waters of arrangements and be actually a part at that negotiating table, setting down the arrangement and making sure that MCOs and providers cannot reach level 2 arrangements and upside and downside risk without having a CBO as an equal partner. But because we as a state don't see CBOs to be a real provider, but are putting some requirements on them to be as a provider when it comes to the contracting, we'll be relaxing those requirements in order to allow CBOs to become those on an equal footing basically with the providers, yet recognize that they'll provide maybe not direct patient care, but this indirect care that's a key for the population health. So that's coming up. It's something that we will, I think Martina will tell you about, and we are working on coming up with a template that will help CBOs actually enter into arrangement and then avoid some of the issues that we've heard that we ask providers and MCO to submit a standard clauses, the Medicaid standard, set of standard clauses to us, which is basically what binds provider to provide care and services in accordance with the public health law or social services law, which really doesn't bind CBOs. So we heard that some of the oppression has been, or some of the discussions have been that CBOs did not feel comfortable signing those contracts, especially because Tier 1 CBOs don't even bill Medicaid. So why should they abide by these very stringent Medicaid rules that are really set for providers? So for those reasons, we're trying to maybe even a little backpedal on what we've said originally and try to include CBOs as a partners in our contracts. We'll learn too. I mean, you know, this process of traveling through the state and talking to providers really educates us as well, because you know, it's great to have this value-based payment idea sitting in Albany, in OHIP, and talking about how we want to move towards value-based payment, but really we learn what it takes and who are the people that do that once we go out and meet folks like you that provide the, you know, social determinants of health type of services, or people that provide primary care or anything else. And you are our scale or to tell us whether ideas that we have really would work. And we are in this value-based payment for a long time, so we want input from everybody, from the providers, because we are changing the environment of how care and services are delivered in New York. So you guys are integral partners in that. So Martina will provide a little bit more about, you know, level 1, 2, and 3 CBOs, because I really do not know much about that. Okay, so contracting life cycle. So this we developed basically just to summarize 5 steps of the contract, how the contract comes to life. The negotiation being the very first one. If you click to the next one, I think we can start there. And so negotiation is the very first step in a contract. Department of Health, it's not a party to negotiations. This is something that happens between the payer and a provider, the MCO and provider, be it an IPA, ACO, or a provider directly. We have spoke to managed care associations, and we were told that those contracts can take between 90 to 180 days, sometimes even much longer, depends on the complexity of a contract or an arrangement that they're trying to negotiate. So because we're not party to the contract negotiations, we cannot tell you what happens during the negotiations, but we did come with about 10 best practices or things that we would like to see in a contract once that as the contract's being negotiated and submitted to us for review. So, do you mind flipping the slide so he can? No, you can do your work. Okay. Okay. So, so we came up with a set of best practices. So, very first one, it's identify who you are contracting with. So as I mentioned earlier, the only parties that can contract for services in New York are MCO, IPAs, ACOs, and providers directly. So understanding that, and while PPSs are a valuable partner in achieving district goals and moving the population health, PPSs as themselves cannot contract with the MCO. PPS needs to either become an IPA, Independent Practice Association, or Accountable Care Association in order to contract for provision of healthcare services. Even though PPS is our provider and really provide that healthcare services, but law is the law. So understanding who your partners are and know that only contracting people are the IPAs, ACOs, and direct providers. Engaging with these providers early and often, so collaborating, talking, sharing experiences, it's the key. And then consider partnership with the CBO organization. there is no level 2 or higher contract without having this. This is an absolute must for the value-based payment arrangement, engaging those social determinants of health and improving that side of the health for a person it's key for the value-based payment. So we will not approve a contract, value-based payment contract 2 or 3, level 2 or 3, unless they have a CBO, unless they have a contract for the social determinants of health with a tier 1 CBO. Yes, please.
Real quick, is there like a directory of IPAs, ACOs? I mean, how do we know who's an IPA, who's an ACO?
I'm not sure. I can look into that. I don't know if... I know for CBOs that there is a list, but I didn't know if there is anything for IPAs and ACOs. Is that posted anywhere? Okay. So there is, we can share a link with all of you guys. Ryan tells me that there is a list, maybe not all-inclusive list, but there is a list posted with a running list with CBOs, some IPAs and ACOs, or at least larger groups that we know in the state. The second step, or the second best practice, is negotiate with the right people. So the time is of the essence. So knowing who the parties that you negotiate with, it's a key. And then again, engage early and often, which means keep those relationships going, keep talking and proliferating those relationships. Understand your organization's capabilities. This is, I think it's important to understand that level 1 does matter. So don't feel as a provider that you are pushed into taking that level 3 per member per month prepaid capitation, or even going into that high level 2 risk where you actually might suffer some losses. Level 1 value-based payment arrangement, where your provision of care results in some good quality measures that actually will change and provide value, and then you can get savings out of it. That's the way to go. If that's what's comfortable for a provider, that's the way to go. There is no need to push into the higher level arrangements. Although we as a state have a target, or CMS gave us a target of 80 to 90% of all managed care payments in a value-based payment by 2020. Only 35% of that 80 to 90%, it's in level 2 or higher. So a chunk of our arrangements, we understand, will be in level 1, and we do not want to make the healthcare delivery in New York unstable by pushing everybody in level 2 and level 3. So understand your organization capabilities, know your mission, your finances, your ability to take risk, understand your data capabilities. Data is the key. Data exchange is very important. And your partnerships, as well as understand what are the state processes, what are the timelines that you're working against, because even though we're moving towards the value-based payment, we're still a bureaucrat, so everything takes time. Thank you. Spell out all the details. If it's not in writing, if it's not part of the contract, it does not exist, unfortunately. So during negotiation, it's really important, if something really matters to you as a provider or you as a payer, make sure that it's in a contract. Spell it out and write it in, because down the road, if there are any issues with a contract, or if there are any issues and you want to terminate the contract, you know what are the rights. So make sure those rights and the details of the contract are spelled to the best possible. And again, define the milestones and time frames. This is the reporting. It's a great milestone. You can put the stops or checkpoints in a contract where, every 6 months, the partners, the provider and insurer will meet. Provider and exactly insurer will meet and talk about data exchange, talk about results to date and things like that. If you put it in a contract, then you have to obey it. Yes?
What about accountability for the MCOs in paying once you have an agreement? So I have several agreements with MCOs, but they don't follow. There's no accountability. I can negotiate with them, but there's no accountability when they change the rules and don't tell me, or they do this and delay payment. If they want to be a New York State certified and approved MCO, should there be some accountability once we have an agreement?
And thank you for that question. Our division actually surveys and oversees MCOs, and we do have a bureau that actually deals with complaints. So if there are ever issues like that where your payment's lagging or they're not obeying the contract, you should let us know.
I wrote your name down.
Good. Do you know the spelling of my last name? I'm just kidding. Yeah, Burr, there we go. No, just make sure you let us know. We do people who investigate that, and we do oversee the plans and survey them every year. There's either, every 3 years by law, we have to go and review the plans, and we can also do ad hoc targeted survey of the plans if we hear more of complaints of one specific payer.
I was thinking of something mandatory in the contract that would actually do something to them, because what would hold them accountable to a point where they would want to change whatever that practice is they might be doing.
Well, part of the standard clauses is the prompt payment law. If it's only the payment, they have to obey by the prompt payment standards, which is the Department of Insurance law. So that is within our standard clauses. Both providers and the payers sign those standard clauses, so they should hold true to what they sign as well. Ryan's writing a note. It's something that we will bring to Jason on our next, we have these weekly SteerCo meetings with Jason Helgerson. So we'll bring that to him and see if there is any more hammers we can put down on MCOs to collaborate a little bit better with payers and hold true to their part of the deal as well. And if any issues, make sure you let us know, because we will not know if we don't hear from the providers. Keep the approach format and the language straightforward. Folks who review our contracts in Department of Health, who approve and oversee the contracts, are not lawyers. The contracts are legal documents. So to the extent that you write these contracts in a layman term and something that folks can understand on our side, also folks that work, not providers are not lawyers either. Part of the people that negotiate contracts for the MCOs are not lawyers. So understanding and writing in a layman type of terms that everybody can understand, it's much better. So try to avoid the contracts from the too many legalese and that complicated language that nobody will understand when push comes to shove and you're waiting for your payment and there is, oh, it's in a little print or some of that. Make sure that it's clear. And then try to stay on menu arrangements to the extent possible, if possible, because of the fact that we provided so many resources to you to help in achieving the arrangement and targets and goals of the arrangement. So try to stay as close to the roadmap as you can. Specific payment terms, this is a requirement of the law. So payment terms as to how provider will be paid, what is the time frame for payment, has to be in that contract. We as Department of Health will not approve the contract if it does not have the payment terms specified in it. So make sure that that's in it. And as a provider now in a value-based payment, I think you have a little bit of an upper hand to fight for some of that too. So you don't have to just listen to MCO and sign on the contract. You can argue a little bit and maybe push some of the agendas that you want, were specific to the payment terms or specific to the time frames or check-in points, as I keep saying each and every time we go through these slides. So they're accountable for it as well as its provider for providing the care. Monitor progress. Decide how deliverables such as data, target budget, and utilization will be collected, monitored, and reported and exchanged. And you guys already know about budget and that little provision that is the partnership between the MCO and the PPS for data sharing. So this is it. I mean, we're trying. So we hear from what people tell us around the state and what are the pain points in moving towards the value-based payment. And that specific provision in the executive budget about PPS and payer partnership plans is because we heard that MCOs and PPSs are not really engaging, or the MCOs are not sharing data willingly with the PPSs. So we do carry message after we travel around and we tell it, and then, you know, Jason's pretty big on moving towards the value-based payment, and we also do have confirmation that our new Medicaid director, who many of you already know probably because she's been around for almost 30 years, Donna Frescator, is very much into the value-based payment. So whatever we hear here, we'll carry on down to SteerCo with Jason and Donna, and we'll try to do best in implementing some of the recommendations that you come up with.
We have a lot of slides left and a lot of great questions, about 10 minutes before the panel session.
Okay, good. So let's quickly run through this. Keep it confidential. The HIPAA, you guys are providers, you know what that means. Make sure the data is it's confidential. And agree on circumstances that terminate the contract. This is important to put in a contract before it comes to the point where you need to terminate the contract. So if things like that are in a contract, it's easier to actually maybe come up with some ways to ameliorate the issues rather than terminate the contract, and agree on ways to resolve disputes. Again, put it in the contract. It's easier to come up and negotiate the disputes rather than go to litigation and spend money on that. Next slide, please. Oh, I can speak fast, but you will not understand the thing. So this is the 5 steps for the beginners. It's pretty much summarizing what I've told you before. Assess your readiness for value-based payment. Determine if you have an existing contract that you can easily amend to move to the value-based payment. Align your VBP arrangement to the strengths and strengths of your business and your business model and your business partner. Build partnership, collaborate, and familiarize yourself and utilize available resources. Stay on menu if you can. Next slide, please. This is for 5 steps for experienced contractors. It's pretty much similar as the other ones. It's just understanding where you are currently and continue to move forward. Reassess your capabilities, your network partners, and see if those are still working or you need to engage with some other ones. Consider reinvesting savings in another innovative interventions. So, if you're on level 1 arrangement and you suddenly started getting all the savings for providing that awesome care that you do, maybe you don't want to just pocket that savings and, expand on a building. Maybe you want to invest in additional services to your members. Keep current with yearly benchmarks. We do post that annually on the MRT website. And where feasible, continue to improve and strengthen your data and data analytics. Next slide, please. There are really lots of slides. So that's negotiations. As I said, takes 90 to 180 days. The next one is actually MCO is the only entity that can submit that contract that was negotiated to us for review and approval. It takes about 15 days for them to send it to us. So don't worry if you don't, you negotiated contract on Monday and you don't have any results from Department of Health on Wednesday. It takes MCO some time to put additional documentation in with that contract and send it to us. It's really a certification form that we require each contract to have that has to come to us, and then we start our review. Next. This link actually works. I hope these will be shared and you can actually get to the link. This is where our checklists are. It's a document, 2 documents we developed, actually multiple documents, but really 2. On-menu and off-menu checklist we developed for our staff to review contracts in a more of a consistent manner. We have several people that review contracts, but because all contracts have to follow a very specific 8 or 9 items that I mentioned earlier above, we created a checklist that tracks along those items so people can basically just check off and approve contracts in a timely fashion. You can move on. So this is our contracting process. We review contracts in 3 tiers. Tier 1, it's file and use. It's a 3 business days review for us. This is really for those level 1 contracts with upside-only arrangement, but it's a smaller contracts under $1 million. Only Department of Health reviews those contracts, and we only perform programmatic review. Basically, what we do is check that contract has that certification statement appended, the body of the contract is in it, and that all parties have signed the contract. We do some random sampling down the road just to make sure that those contracts actually tracked by the value-based payment roadmap. Tier 2 review, it's the DOH review. This actually involves the financial review as well. It's for more complicated contracts, the ones that are level 2 or higher, so above $1 million threshold. And also, as you see, there is more than 15% of the provider's total medical revenue is at risk in that contract too. So that review is about 90 days. It's a very thorough review by our staff, both programmatically and financially. And then tier 3 contracts are multi-agency review contracts. Those are your prepaid capitation contracts. They actually abide by the Regulation 164, which is Department of Financial Service Regulation. Those are prepayment arrangements. Department of Health only reviews the programmatic side of that contract, and DFS reviews the financial sides of that contract. This is basically what I already told you. The tier 1 contracts are 3-day business review. In order for us to approve the contract, it has to have that certification statements, which is DOH 4255. It's actual form, it's fillable, it's on our website. and then standard clauses for managed care providers, which have, these standard clauses have to accompany each and every contract because those are basically regulations and laws that providers and payers have to abide by. The financial review happens in a tier 2 review. Those are for those million or higher contracts where there's actually 15% of more risk being passed down to provider. And as you see, we do sort of a bifurcated review for services that are provided directly by provider. We only do the demonstration of provider financial viability, and we usually look at the pro forma financials and a balance statements that providers have to submit via MCO to us. And then if provider fails to demonstrate financial viability, we will only impose the financial security deposit. For Medicaid providers, in level 2 contracts, that financial security deposit is 7.25% of the in-network capitation. Provider actually has to put that and give it to the MCO to hold. That's a reserve to ensure that the members will not be, not lose services or care, and the claims will be paid. And then for services that are paid through the IPA or an ACO, we do that financial provider viability by looking at the pro forma financials or balance sheets, and then financial security deposit is assessed. And again, it's a 7.25% for the Medicaid providers. If the arrangement's level 3 or higher, that financial security deposit goes to 12.5% because it is how it is in the Department of Financial Regulation. It is how it's in DFS's Regulation 164. Financial security deposit does not have to be in a form of cash only. We do take letters of credits, parental guarantees. There is also some other like reinsurances and things like that. So it is spelled in our provider contracting guidelines. And I understand that in the package that you have gotten this morning, there is a copy of provider contracting guidelines within, and does speak. There is a lengthy section that talks about financial security deposit. Next slide, please. This is quickly a checklist that we've developed that I told you for our staff to review the contracts, and it's very simple. The very first question is types of arrangements, and are those type of arrangements aligned with the roadmap or not? Definition of scope of services, I told you already. Each arrangement that we recognize as OHIP's preferred arrangements come up with a list of services that have to be included for. So for total care for general population, all services that are currently available to the Medicaid managed care person receiving services are required to be in a total care for general population arrangement. IPC and maternity and all of them have a listing of services in a roadmap that we specify and have to be included in that arrangement. We'll look for that, we compare to the roadmap and put a check mark if they're there. Quality measures and quality reporting. We put the questions here, and you see that a requirement for the value-based payment contract is that all contracts have to report on, value-based payment contracts have to report on all reportable Category 1 measures. Those measures are HEDIS and QAR measures, and the CAG reports or playbooks actually list those measures. I did mention earlier the 2018 Category 1 measures are posted on our website. Next slide, please. Risk level, is it a value-based payment level 1, 2, or 3? And based on that, is it upside only or upside and downside risk? Shared savings and losses. Does the risk level correspond with the shared savings and losses minimum, which is stated in Appendix X of the roadmap? And does the contract list that at least one pay for performance Category 1 measure, quality measure, that it's tied to that shared savings? And then attribution, as I said, it's something that you negotiate between the payer and provider, and based on the membership that you have, who will be part of the arrangement that you're moving on to. Next slide, please. Target budget, we talked about that. Social determinants of health, all contracts that are level 2 or higher have to show a commitment to implementing at least one social determinants of health, and they have to also have a contract with at least one Tier 1 CBO. There are some dispensation given to the rural areas where there are not really CBOs available, and those waivers are submitted and approved by the Bureau of CBO that we have recently developed, and Martina will tell you about that a little bit later. Next slide, please. Off-menu arrangements. We have, since this slide has been put together, we have developed an off-menu arrangement checklist. It's posted at the exact same place where the on-menu arrangement checklist is that link that actually does work. Any arrangements that are submitted to us as an off-menu probably require a 90-plus day review. The review is completed by collaboration of many different parties. We include our finance folks, our rate setting and finance folks, people from the quality side, as well as folks from our division. So it's a collaborative process, lots of different moving pieces in it, so it takes us it's longer time to review. As long as these 5 criteria are kept or kept in mind while negotiating off-menu arrangements, you'll pretty well be reviewed within 90 days. So you should focus on the underlying goal of the value-based payment reform, focus on conditions and subpopulation that maybe we did not address in a roadmap, be patient rather than provider-centric, and focus on both components of value outcomes and costs for cost care delivered. And off-menu arrangements should utilize standard definitions to the extent possible. Okay, so that basically concludes our review. 3 days for level 1 contracts, 90 days for level 2 or higher contracts. To date, we have reviewed all contracts that have been submitted to us in accordance with that timeline. Unless the contracts have missing something, in that case, we would send you a letter within a 1 business day telling you that the contract's not approvable as such, and then come up with the suggested edits that need to be included in the contract. One more slide, Dr. Foreman, please. Why do we do this? You know, it's because we love contracting, but it's really because we are required to do this. Public health law and insurance law require us to review the contracts. And it's really to ensure that providers are capable of assuming the risk. They will not constitute improper incentives or result in deterioration of access and quality of care to enrollees. That's the reason why the Department of Health review the contracts. And then DFS, it's required by their regulation to review all prepaid arrangements, because that's where the insurer actually is passing down some of that insurance capabilities to the provider, and provider starts acting as an insurer. Next slide, please. And one more. So once those 4 things of the cycle are actually accomplished, Department of Health reviews and sends a final approval to the contracting parties, and a contract can be implemented. Throughout the term of a contract, we do survey and oversee the contractors, as I mentioned before. It happens on a regular basis, or we can do an ad hoc review on visits of the plan or a provider based on a complaint that we have heard, or just to do more focused review of a certain components. If there are any material changes to the contract, you started working on it and 6 months down the road you realize that whatever you agreed in that contract maybe does not work, and you want to slightly change it or amend it, you have to send it back to us to approve it, which basically goes through that cycle again, or a life cycle again. Next, please. Okay, so this is, I don't work with a patient-centered medical home, but it's a request that has been posed by you guys to talk about this, because we have proposed some changes to the patient-centered medical home in the most recent Medicaid update. So if you move one more slide. So this is basically summary of what has been proposed just recently. I think it was January or maybe even February Medicaid update. So just quick factoid on patient-centered medical homes. Since 2010, New York has been financing incentives in both managed care and fee-for-service for practices meeting the NCQA recognized levels of PCMH. You see over 2,300,000 Medicaid members have been receiving services by providers, about 7,000 of them who are NCQA qualified and recognized. Medicaid has a goal. This is important. Medicaid has a goal whereby all MCO designated PCP will be NCQA PCMH recognized and fully embrace the delivery of more integrated and value-based care. Next, please. Unfortunately, it's tough times with the finances, so we had effective, oh no, you can go back, sorry, it's my bad. So due to the fiscal constraints and the Medicaid global cap constraints, Patient-centered medical home incentive payments have been actually reduced for only on a temporary basis for 2 months. We're not going to be paying any payments for the managed care, as you see, for period May 1, 2018 to June 30th, 2018. Practices that are recognized under the NCQA 2014 Level 3 or NCQA 2017 standards will receive a temporarily reduced MMC rate of $2 per visit, and the patient-centered medical home for the fee-for-service will remain $25.25 for professional and institutional claims, respectively, only for that period of time. All incentive payments for PCMH recognized providers under NCQA 2014 Level 2 will be completely eliminated. So you want to move folks towards the more recent NCQA designation. Next slide, please. Effective July 1st, however, we do propose some changes to the incentive payments, and those payments will be modified and increased with a movement towards the value-based payment. We will engage key stakeholders to focus on making those sustainable fiscal recommendations that are in line with the Medicaid global cap spending and also in line with the PCMH program. And will reward providers who actually move toward participation at least VBP level 1 or higher. And projected rates for the MMC payments will range between $5 and $6 for providers with a VBP contract and will remain at $2 for providers that do not have VBP contracts. This is something that state is going to start engaging stakeholders in. And just earlier this week, actually, we published a document. It went out to the public comment. I'm just trying to find what's the name of that document. The public comment is due on April 4th and actually is MRT structural roadmap. And there's a section in there that speaks more detailedly about changes to the patient-centered medical home program. And it basically asks for participations for providers on a work group of stakeholders that will be actually coming up with the ways to reform and reform the patient-centered medical home program in New York. I'm sweating now because I'm speaking so fast. I might need medical care after this. Okay, so this is, I think it's the first time we're talking about this in a large group like this. It's really our state progress to reaching those 80 to 90% goals. Data's a little bit late, a little bit old. We are actually collecting the newer data and hopefully post it on MRT website within a month or so. So this is the reason why we are doing what we're doing. So we're basically surveying the MCOs currently to collect information on where are they in progress towards moving to that 80 to 90% goal. These references speak to why do we have to report this to CMS. So next slide, please, actually goes into a little bit of a detail. So we collected data so far is a base level calendar year 2014, has nothing to do with value-based payment. You know, we just wanted to do this awesome experience before value-based payment and then move it over as we move towards the value-based payment. So year 1, calendar year 2015, we collected data. Calendar year 2016 data, we also collected. This is basically us polling the payers, the MCOs, to tell us what type of arrangements they're getting into with providers. What I will tell you, the couple next slides talk about this calendar year 2016 data. In order for us to align with the district measures, we slightly changed our survey to payers, and we changed the data changed the collection of data from the calendar year to the state fiscal year. So just earlier this week, I believe on Tuesday, just yesterday, we received the responses from the MCO for the state fiscal year April 1st, 2017 through December 31st of 2017. So we're still scrubbing and refining the data. Not still, I mean, we're still waiting for some MCOs to submit the data, and hopefully within a month or so, we'll be able to present more accurate data or more current data of where we are in that progress. So Dr. Foreman, one more slide, please. This just tells you about survey tool. It goes out to MCOs. There are 4 tables in it. We ask for the medical expenses by arrangement, expenses by region, and then a contract-specific information. This is what we use to validate the contracts. MCOs can tell us they have, you know, all their dollars are in managed care, but if we didn't approve that contract, we don't trust. So trust and verify. So we ask for a very specific identifying number on a contract to be included in our survey so we can actually pull the contract and verify that indeed is the value-based payment 1, 2, or 3. Next slide, please. So we collected data for, as you see, 16 mainstream plans, 13 HARP plans, 3 HIV SNP plans, 4 Medicaid Advantage dual plans. Our most recent survey, the one that we just got yesterday, actually collects data for all these purple guys as well. And there is a schedule here when we send out the surveys and when we expect data to come back. So next slide, please. It's actually the meat of this whole spiel that I'm doing here. So this is based on a calendar year 2016, only includes data for mainstream managed care plans, HARP, and 3 HIV SNPs. As you can see, at that point in time in 2016, which is a calendar year basis, we have $22 billion going to the managed care entities throughout the state. And majority of that dollars was still being spent in 2016 on a fee-for-service arrangement, non-value-based payment arrangement. That's that big blue box or a big blue piece of the pie. Value-based payment, 0, level 0, that, just shy of the value-based payment 1, 2, or 3. Still about 13% of the payments are going in 2016 to those type of arrangements. As I said, we're working very closely. We actually scheduled calls with each and every MCO starting mid-April to talk about ways how to help them move towards the level 0 to level 1 or 2. And then as you see, we also collect the data for what is that level 0. What is missing? You see about 12% of all those dollars is spent on the level 0 arrangements that have quality components. Maybe those are your withhold or bonuses paid on certain quality metrics, but they are missing target budget or maybe missing a very specific attribution. And then, as you see, only about 1.2% of all payments is spent on a cost only, based on a target budget, but no qualities whatsoever. So our goal is really to reach to those folks that have level 0 payment and are just that slightly shy of reaching, of amending those contracts and move that 13% towards the value-based payment and therefore achieving that 80 to 90 goal much quicker. As you see, in 2016, about 9% from what I see. Yeah, I can't tell. That gray box, that's a value-based payment level 1. Level 2, about 27% of payments to managed care entities in calendar year 2017 were on level 2 payments. As you see, as a whole state in calendar year 2016, we already hit 38.32% of that 80 to 90 goal towards the value-based payment. Come April of 2019, I believe, it's the first measurement year that we have to prove to CMS that we actually are moving towards the value-based payment. Our goal is 10%. We surpassed that goal. So we're doing awesome. You guys are doing great. Next slide, please. This is just a summary. I was not given permission to tell you about this year in detail, but the data from April through September of calendar year 2017 trends to about 44% of all managed care payments are in some type of value-based payment arrangement. So we jumped from about 38% to about 44%. Once we get that data through December, we hope that that will just continue to climb up. So this is basically what happened over the 3 years that we've collected the data. Calendar year 2014 is base level. That's before we even started talking about value-based payment. But, don't want to be ignorant. Folks have already doing value-based payment before we as a state started talking about it. So there was about 31% of payers have been paying providers on some type of a value rather than a volume-driven metrics. In calendar year 2015, about 34% of payments were in value-based payment. Calendar year 2016, 38%. And as I said, to date, 9 months of calendar year 2017 show about 44% of payments are being paid to providers on some type of the value-based payment or in some type of the value-based payment arrangement. Next slide, please. There's only 2 more slides. Okay. This is just a quick summary of type of arrangements. Basically, we collected data on what type of arrangements providers and payers are paying on. And as you see, majority of payments still in fee-for-service, but the biggest one is total care for general population. There is a little bit of integrated primary care and some small amounts for the HARP and HIV AIDS subpopulations, but majority of payments are going to the total care for general population. And the next slide is sort of a regional slide, I believe, and tells you how do we fare regionally. These regions are managed care regions. Those are regions exactly the same as managed care submit their operational cost reports to us, so they're not well, you can tell what they are. Central Finger Lakes, Long Island. The biggest movement is happening in New York City, of course, but the biggest volume of care is provided in New York City. And as you see, about 44% of payers in New York City are paying on some type of level 2 VBP arrangement. The largest one, I'm not going to single them out, but Health First is doing, and I'm not going to single them out, I'm just going to name them. They're doing pretty well on paying on a value-based level 2 type of arrangement. Long Island pretty much trend the same way. And as you see throughout the state, folks are slowly moving towards the value-based payment, some better, some worse. But this, again, it's only calendar year 2016 data. The results are much better in calendar year 2017, and hopefully we'll post that on the website.